This is open for questions. If you have any questions, congratulations on a wonderful presentation. Mario?
Yeah, I guess the obvious question is, what's your clinical experience with the tool so far, if any? In other words, I guess you're going to be looking at sizing and paravalvular leak and trying to compare that to some other technology, for example, CT. Have you done any of that work yet?
Yes, we have. And so the software has been so far validated using 15 patients, where we take the gold standard to be CT. And so the annulus that was predicted from the software is compared with that of CT. We were blinded to the CT result prior to operating the software. And on these 15 patients, 5 of the 15, so about 33%, would have had the improper size of TAVR valve implanted had the size of the valve been selected from 3D echo. Using our software, 1 of the 15 patients would have had the improper size. So clearly it's a clinically significant benefit for those patients.
But I guess, paravalvular leak's a complicated occurrence. I mean, there's a lot of things that impact it, not only sizing, but just the anatomy of the valve in general. But have you looked at that? I mean, I see what you're saying, and we know that, as you mentioned in your presentation, under CT, 3D echo underestimates the size of the annulus, but have you looked clinically to see what impact it's had from the standpoint of paravalvular leak?
So the preliminary validation studies were done retrospectively. So the data that was used to size the valve was the CT data. The data sets that were used to generate the preliminary data that he presented was basically computed from the measurements of the pulse Doppler from the 3D echo done on the TEE.
Okay, thank you.
The CT scan is used not just to size the valve, but to evaluate vascular access. So even though you're eliminating the CT scan for the sizing, don't you still need to do a CT scan to make sure that the aorta can take the valve, et cetera, et cetera?
Certainly for peripheral vasculature, CT is the gold standard, but you can actually perform a non-contrast MRA and assist it in times with direct vascular Doppler. So you can do a completely non-contrast assessment of the peripheral vasculature.
So we'd also add that as the size of the catheters for the transcatheter valves go down, then the need for peripheral vascular access CT is also likely to be reduced.
Well, maybe. You still need to assess it some way. MR, ultrasound, some assessment, even if it's 8 French, because some people don't have that kind of access. So you'll still need some assessment of peripheral vasculature to do the procedure.
Yeah, but that could be done without contrast.
Yes, I agree.
You mentioned the black box a couple times, but specifically I was curious about the machine learning aspect, where is it just learning from only the 15 patients that have come on from before, or what type of data is getting fed into this?
No, so in the black box, actually, which is a patented technology, we have issued patents on the technology, is based on computer modeling, simulation, computational fluid dynamics. And so it's an iterative process that involves solving Navier-Stokes equations under viscous flow conditions. And we couple that iterative process with a machine learning algorithm that helps do the iterations as fast as possible so as to minimize the turnaround time. Yeah.
So if I could translate to the non-mathematicians in the audience, including myself here, is basically solving a continuity equation with 2 missing variables, which is the effective aortic valve orifice and the LVOT area, which is something that you wouldn't do unless you have this complex differential equation.
How do you deal with Doppler alignment issues? You may not be getting the highest jet, and it seems that your black box really depends on at least the velocity or the shape of the Doppler signal.
Yes.
So I think the assumption is that if you have an angle misalignment, it will affect equally the pulse Doppler as a continuous wave Doppler recording. So a underestimation by 10, 15, or even 20% will affect both equally. Therefore, the calculation will be still valid.